invite Dr. Raskob to present their data.
Thank you, Dr. Brodsky. Good morning, and thank you for your interest in covering this and getting the messages out about these research findings. So as was mentioned, we're going to talk about venous thromboembolism, blood clots in the legs and lungs, which can be fatal and which are a common complication of many cancers. The treatment of these cancer-associated venous thromboembolism, or VTE, is challenging because the risk of recurrence and the risk of bleeding complications with treatment are both higher in the cancer patient than in the non-cancer patient. Both of these complications are important. They contribute to mortality, morbidity, but importantly for oncologists, they may interfere with what they really want to do, which is give definitive anti-cancer therapy to the patient. And so avoiding these two problems is very important. Evidence-based guidelines recommend the use of low molecular weight heparin, which must be injected subcutaneously for at least 6 months and longer in many patients. However, we know that subcutaneous injection is burdensome to the patient, limits its adoption by both patients and clinicians. The direct oral anticoagulants, which have been shown to be effective and safer than other anticoagulants in patients, the broad population with venous thromboembolism, may be an attractive way to treat these patients, but they've never been directly compared to the standard in this cancer patient population, low molecular weight heparin. We therefore designed the Hokusai VTE-Cancer trial, in which we took patients with objectively confirmed venous thromboembolism by imaging who were cancer patients, adult cancer patients, and randomized them to a standard of care treatment, low molecular weight heparin, Dalteparin, shown on the bottom line here, 200 units per kilogram, followed by 150. That's a standard labeled dose for this drug. Or to just 5 days of low molecular weight heparin here, followed by oral Edoxaban once daily, no monitoring or dose adjustment of the drug. It's a fixed dose given once daily. Treatment was continued in these patients for at least 6 months. In all patients, that was the intended protocol, and then for up to 12 months in patients at the discretion of the physician after 6 months. The study was done in 114 sites in North America, Europe, Australia, New Zealand. Now, while we treated for 6 months and up to 12 months, we collected outcome data on the patients, on all patients out to 12 months, regardless of their duration of treatment. All of the outcomes underwent independent blinded adjudication by a committee without knowledge of the patient's treatment. And a new thing that has been added into this trial for the first time is the pre-specified and a priori adjudication of the severity of the bleeding events as well, to provide a little more granular information about the nature of these bleeding events, so we might be able to enhance the risk-benefit assessments by clinicians. This is the primary results. We used a composite outcome of either recurrent venous thromboembolism or major bleeding, because prior to the study, talking to oncologists, we couldn't get a clear consensus from them as to which one they thought was more important. So the traditional approach of evaluating efficacy independently and then looking at safety was different in this population, where the goal is to avoid both of these complications and just have the patient being treated and survive free of these complications. And so the time to the first occurrence of either a recurrent thrombosis or a major bleeding event was the primary outcome. The primary analysis results are shown here. 67 patients out of 522, 71 out of 524, hazard ratio of 0.97. This clearly met the predefined non-inferiority margin for the upper limit of the confidence interval of 1.5, and so the result is below 1.5, and statistically significant for non-inferiority, indicating that essentially these two treatments are equivalent for preventing this composite outcome. We also did two sensitivity analyses. One was to look at the results only at 6 months, since that was the minimum intended duration of treatment and was used in prior studies, so we could have some comparative data. And we also looked at a per protocol analysis on treatment. Both of those analyses also confirmed the non-inferiority. So we have 3 different analyses here which are consistent and establish a clear non-inferiority of the oral treatment to low molecular weight heparin for the composite primary outcome. Now, let's look into the components of that outcome, and these were the specified secondary outcomes, either a first recurrent thrombosis or a major bleeding. Let's talk about thrombosis first. You see here that recurrent thrombosis occurred in 6.5% given oral Edoxaban, 10.3 Dalteparin, a risk difference of 3.8% absolute risk difference, which was statistically significant. There were no confirmed fatal events here. Most of the recurrent events were recurrent clots in the legs, and most of the events were symptomatic events, 22 of the 34 here and 40 of the 54 here. So these are patients who manifest with new or worsening symptoms in whom the doctor suspects there's a recurrent clot, and that was most of the outcomes. And when we look at the time course, we see that here on the horizontal axis is time after randomization from day 0 through to 1 year, and the cumulative rate of recurrent thrombosis on the vertical axis. We see these curves begin to separate somewhere between about 60 to 90 days. What this likely is reflecting is that's about the time that a number of patients start to come off their injections and just don't want to continue it anymore. And that's known from good analyses, other data in the literature. And you see that then these curves separate and continue to be widened throughout the remaining year with the lower recurrence rate on the oral medication, in part reflecting the fact that patients are better able to adhere to that medication. Now, when we look at bleeding, we saw 6.3% major bleeding event. The definition of a major bleeding is that there's some bleeding and the hemoglobin is declined by 2 grams or the patient was transfused with 2 units or more. And we see that being 6.3% here in the Edoxaban group and 3.2% in Dalteparin. So a similar difference, but an increase in bleeding with the oral drug by a similar rate that offset the reduced recurrent thromboembolism rates. 2 intracranial bleeds versus 4 in the low molecular weight heparin group. And you see that most of the excess bleeding was due to upper GI bleeding in these patients. Almost all of the excess bleeding was due to upper GI bleeding, and it was predominantly clustered in patients who entered the study with GI cancer at the time of entry. Now, we, at the beginning of the study, pre-specified that we were really going to look a little more detail at the severity of these major bleeds, because the traditional marker of hemoglobin change or transfusion in this population may not be as useful because the patients have other reasons for their hemoglobin to be declining or to be receiving transfusions. So what this means is we defined 4 categories of severity of bleeding before the study began. Category 4 is fatal bleeding. Category 1 is bleeding that doesn't require any other measures, so it's the least severe. 4 is the most severe. Category 3 is life-threatening emergency bleeding, such as intracranial bleeding or bleeding leading to a drop in blood pressure or rapid heart rate or hemodynamic instability. And category 2 is bleeding that is not a clear emergency but requires some type of modest interventions of the patient. What you see here is quite interesting and confirms what we had found in the larger trials of the direct oral anticoagulants in both atrial fibrillation and in venous thromboembolism, that the bleeds that occur on the direct oral anticoagulants are less severe. You see that 2/3, 64% of them are category 2 or less, whereas 71% of the bleeds on Dalteparin are category 3 or higher and are life-threatening or emergent bleeding events. And so when we look at the incidence of severe bleeding on the bottom, category 3 or 4, this was similar between the 2 groups at 2.3%. So there's a little bit of excess bleeding with the oral anticoagulants, but it's not as severe, and the severe bleeding is similar between the groups. Finally, this is what I think matters to oncologists, and I'm sure many of you are used to. That is the patient alive without complications? So the event-free survival, which was a pre-specified secondary endpoint, is shown on the horizontal axis. You have time after randomization out to 1 year. Vertical axis are the proportion of patients surviving without having a recurrent thrombosis or a bleeding event. And you see the 2 curves are almost entirely superimposed, and we progress to an event-free survival of about 55–56% in these groups at 1 year. So in conclusion then, Treatment with the oral Edoxaban once a day is non-inferior to subcutaneous injections with the low molecular weight heparin Dalteparin for preventing the composite outcome of recurrent thrombosis or major bleeding. The lower rate of recurrent thrombosis with the oral drugs is offset by a similar increase in the risk of major bleeding. There was more upper GI bleeding with Edoxaban, mainly in patients who entered with GI cancer at entry. The major bleeding is less severe with the direct oral anticoagulant Edoxaban. Rates of severe major bleeding were similar, and survival free of recurrent VTE or major bleeding was similar. Thank you.